Hi, good afternoon, everyone. Thanks for joining our monthly meeting with all providers. I am Michelle Fry, and I'm joined here at DDSN with a number of team members. I think everyone has already met, but we have Tracy Hunt, Lori Manos, Ann Dalton, Julie Cook, Debbie P., because I can't say her full last name appropriately, and she's not upset about it. And also, I'm excited to announce that we have 2 new team members at DDSN. We have a new CAO, Dr. Harley Davis. She's at the table. I don't know how well folks can see our screen, but she joins us from DHEC, and we're really glad to have her join the team. And we also have PJ Perea, who is our new public information officer, who will be doing a lot of our communications and outreach work. So I think that you all can see them on the screen, but we want to have a hearty welcome for them and introduce them to our provider network, because I'm sure that you all will have opportunities to interact with them. And other than that, I think we're going to dig right into the agenda.
Perfect. So I wondered if perhaps Margaret Alwine from DHHS wanted to go first about the go live date for direct billing, because I think that's kind of at the forefront of everybody's mind right now. So Margaret, if you want to kind of give a couple of updates from your end, then I can give a couple of updates from the DDSN end, and we can take any questions. And then you're welcome to stay for the remainder of the agenda, but I know that your time's very valuable, so you can go ahead.
Great. Thank you. Let me test my audio, see if y'all can hear me.
We can hear you.
Great, thank you. Just wanted to give a few updates. Here we are at March 30th, and our go live date is April 1st. So we're all very excited about this milestone. I want to thank everyone for your partnership and your cooperation as we have moved through this transition. I feel like we have worked together to make sure that this transition is a smooth one, and that you all are supported throughout the process. So with that, I will add that after the go live date, we have set up a daily task force meeting. So we will be reviewing reporting and input on claims processing as they begin to come in. Any questions should continue to come through the Medicaid waiver mailbox. That is the same mailbox that questions have come through during the duration of the transition. So we will be reviewing daily what claims are coming in and what issues may be coming up that we can address immediately. Again, it's our intent that we continue to provide support and that the transition is a smooth one for you. Additionally, we will be issuing additional communication that will be in the next week or so. We've gotten a good bit of questions on cost reporting, our process for rate analysis and rate updates. So we wanted to make sure that we got April 1st and this go live date. I see that there's an echo. So let me see what I can do on my end. Lori, are you hearing that?
So every so often I hear a little one, but right now I'm hearing you okay.
Maybe if I speak very slowly.
It's going okay right now. Like I said, I've heard it a couple of times, but we're not hearing it in this room very prominent or anything. We can still completely understand you.
Okay. All I have on is my laptop, so I don't know what else I could turn off.
Yeah, I don't think that, I know I don't have any sound on, and I think I might be the only one in the room signed into the meeting.
Okay,
I think we're fine.
all right. So additional communication will be coming out in the next week or so to address questions that we've received on cost reporting, on rate analysis, and updates to rates. We wanted to ensure that we got April 1st and the go live squared away as smoothly as possible, and our transition to direct billing. So upcoming in that communication, we will be outlining our approach to reviewing cost and the adequacy of rates. We feel that this timeline and process will be to your benefit as providers, but wanted to give you a heads up that additional communication will be forthcoming related to timelines and rate reviews. We continue to get some questions in terms of enrollment and billing, so we are working those as they come in. We did ask for you all to give updated information. If you had any changes, let me pause for the siren.
I'm gonna mute everybody out there if I can figure out how. Because I think some of the issue might be some sound coming from folks in the audience. All right, Margaret, you want to go ahead?
Sure. So we did request information for any providers that may have changed from the time of enrollment their intent with their billing vendor. We did receive a good number of responses for the updates, but also still had a good number of outstanding. So if you did provide additional responses to your intent for billing vendor, if we've received that by today, we will be doing a second wave of updates through Blue Cross to key those in. If we've received them by today, they should be keyed in by next Thursday, and that will allow for updates to any trading partner agreements that need to be in place. I also wanted to mention that on March 14th, we did send out a notification related to a one-time payment for providers that had enrolled directly with DHHS as of March 30th. So this was intended, despite all of our efforts and extensive work to ensure a smooth transition, to mitigate any unforeseen disruptions. So this transition payment totaling $15 million will be allocated among the boards and enrolled providers based on their band payments. So I wanted to call attention that this communication did go out on March 14th. Jeff Saxon will be outlining and getting with individuals in terms of what that amount will be. So again, just wanted to make mention that that communication did go out. Lori, those were my main updates. Again, we're continuing to triage questions as they come in. We will have a group that will be daily monitoring the claims processing and addressing any issues, providing any additional feedback and support as needed. And so with that, I see one individual response in the chat about that the one-time transition payment that is for waiver services, and if you did not receive it, it was sent out via the Gov delivery system to executive directors. That is the same mechanism we have used throughout the billing transition, and we will certainly be glad to resend that if anyone did not receive it.
Perfect. So Margaret, there were a couple of questions that I think we could probably answer collectively. One of them is about, I don't know the answer to this, so this is probably you. There was an email that was sent out yesterday about Schedule K rate increases. I'm assuming that means Appendix K. Is that on top of the go live rates, or has that already been included in the new rates?
Good question. Yes, that is the Appendix K increases. That reflects those that were effective as of January 1st. So that was not additional on top of the go live rates. That was to ensure we had approval for the January 1 rates.
And then there's a question about, I'm going to read this and answer it because I think it's really important for all the providers to hear. If their app does not have the correct authorizations listed for each individual, will that stop us from billing correctly through the Medicaid waiver portal, or are those systems not linked? So the answer to that question is there's no electronic system to stop you from billing through the web portal if you don't have an authorization. What providers need to understand is, as Medicaid enrolled providers of Medicaid waiver services, you cannot provide a service without a valid authorization. So there's nothing to stop you from billing through the web tool, but on post-payment review, that claim would be recouped because you can't bill for something when you don't have an authorization for it. So that's kind of where I wanted to clarify. I know there's a lot of work being done right now to make sure that authorizations are out there and correct.
Thank you.
That's really not something, the need for an authorization is not something that's unique to a billing system. It's a basic requirement as a provider of waiver services. So the next question is, I need the information on the one-time payment. Okay, so she just basically listed an email address that she wanted you to send that to, Margaret. I can also get you that. When will we get more information regarding the 10% FMAP allocation to home and community-based services providers?
Also a great question. So we were working collectively in terms of operationalizing the activities that were approved through the initial spending plan. One of the next items that we are working with our respective finance departments on was an activity outlined in the DDSN recommended activities and was crosswalked in the approved DHHS plan. That is additional funding for targeted staff retention and recruiting for direct support professionals. And so that is for waiver programs. Again, all of this American Rescue Plan funding is geared toward home and community-based services. That estimated non-recurring cost for those funds to be made available for retention and recruitment for direct support professionals is approximately $7 million. So we are working on the timing and the mechanism to get that funding out the door and to you. So expect for additional communication in short order for updates on the American Rescue Plan, but did want to make folks aware that that is one additional round of funding that in the near future we will be making available.
So Susan has a question about case management data entry. If you'll just wait, I'm going to go through that whenever I go through my updates. And then if there are still questions, we can go through that later. So Margaret, just to piggyback on what Margaret said from a DDSN perspective, the big thing that providers really need to ensure right now today is that they have their authorizations acknowledged and that their attendance modules are built in the TheraP system if they are using TheraP for billing. Like Margaret said, HHS kind of sent something out and asked providers to notify HHS if they intended to bill through a third party like TheraP. There was actually a question of, is it TheraP, is it the web tool, is it a combination, or is it something else? So the ability to bill through TheraP, at least on April 1st or for April 1st, is directly tied to you answering that email. I did go through, and some of the larger providers who had not answered, I reached out to you directly, and I think we've resolved most of those. But there are a few small residential and day providers that have not answered that email. If you don't intend to bill through TheraP or another third-party clearinghouse, that's fine. It would be nice for us to know that that's your intention, but I just want to make sure that people understand that just because the TheraP system is there and it's working right now, it's not going to submit a claim for you, because there's not going to be any trading partner agreement after April 1st if you haven't answered that email. So there's a couple questions about authorizations. If you have an authorization that's incorrect in TheraP, what I would like for you to do is acknowledge it, but include a comment. There's a place on the authorization to include comments. Include a comment explaining that it's not correct and any information to the case manager about what needs to be done to correct it, right? So it's kind of a communication between you and the case manager, and it's a communication for your record that the authorization was sent incorrectly. We do have the ability to delete authorizations. There's actually maybe 3 people in the state that have that ability, but we try really hard not to delete any history unless it's absolutely an error that we find right away, right? It's just like, I hit the wrong button, will you delete it for me now? But you know, I'm really uneasy deleting an authorization that has been out there for months or weeks, because to me that's history of the case, and we don't want to do that. The question from, well, no, I'm not going to go to that yet. There's a question about billing through the current software. What are we required to complete, if anything, in TheraP? So the TheraP continues to be the DDSN electronic healthcare record, right? So there are required things that providers have to put in TheraP to document their service delivery. There's demographic information about the person, there's ISP programs, there's T-logs, there's case notes, right? There are these things that are the electronic healthcare record. None of that has changed. So you, as a provider, are required to use TheraP as the electronic healthcare record. The billing function in TheraP is optional. So if you don't want to use the billing function, you don't have to in order to submit claims to Medicaid. But it doesn't take away the necessity for you to document service delivery in TheraP. The other thing is that if you provide state-funded services to anybody, meaning state-funded day or state-funded residential, you will be required to enter the attendance on TheraP for those services. There will be a report that is required to come with the invoice that documents that service delivery in TheraP. So that's kind of the answer to all of that. Again, I think the big thing related to TheraP, and really everything, is to get your authorizations correct. The ICD-10 diagnosis codes are located on the pre-auths that you're acknowledging. And once you have acknowledged them, you can actually run a report of acknowledged service authorizations. Then, you know, you don't have to do that. So the question is, no attendance logs if we're not billing via TheraP. So from a perspective of using the attendance module in TheraP, there is not a requirement. The thing I will caution you is when you bill for that service in the web tool, you're going to have backup documentation to support the service that you build. So the other thing is that ResLog and DSAL are going to be unpopulated for all waiver participants on 4/1. So you will not be able to use ResLog in order to track or, look at your data after 4/1. It will only exist after 4/1 for people who live in ICFs. The last thing I want to talk about is the case management data entry, which is what Susan was asking about. So we have been spending the last couple of weeks with the temporary staff that we hired doing the data entry for case notes for case managers. It's been a little bit of a struggle because of the fact that there were many case management agencies who had not yet acknowledged their authorizations in TheraP. The first thing to understand is that if you have not acknowledged your case management authorizations in your TheraP account, then that person does not show up on your attendance module, which means we cannot do your data entry, okay? So providers have got to get their authorizations acknowledged and in the attendance module, or we're not going to be able to do your data entry. The only thing that DDSN is doing is data entry. So we're not billing for you, we're not submitting claims, we're not approving the attendance or the units, which is in the attendance module. All we're doing is doing the data entry. We will get something out either Friday or early next week. We cannot enter the first day of case notes until at least the 8th, because there's a kind of a 7-day lag that allows you guys to enter your case notes 7 days after the activity occurred. But we will send something out that outlines on the 9th, we're going to enter information from the 1st. On the 10th, we're going to enter information from the 2nd. And then we are going to give you guys a guarantee of when your data will be entered for each date. So at this point, based on the work that we've been doing, it looks like there's going to be a 14-day lag. So on the 1st, you can see all of the data entry. I'm sorry, on the 14th, you can see all the data entry from the 1st, right? So it'll be like that. And then it'll be up to you as providers of when you want to submit those claims. So there's a question from Robin. Should any service authorization for case management or individual supplies be in the residential or day TheraP account? There should be no authorizations in the residential day account, except for the services that the provider provides. Now, if there's one in your account incorrectly, you can acknowledge the authorization and enter a comment on that authorization that says, we don't provide this service. This case manager has issued this authorization to the wrong place. That way, I think there's this function in TheraP where you can't decline an authorization. So people are kind of hung up on the number in their to-do tab. And it's really, that's a way to get it off your to-do tab. But also document that you do not intend to provide that service. Any other questions about the April 1st go live date? Any support that we could provide to you guys to help you feel more comfortable? Many of you, I've hopped on Teams calls and, that kind of thing, just to try to help you figure things out. So Robin's asking, what if they do provide case management to those people? So for every board who does both case management and residential and day services, you have 2 TheraP accounts. You have one for case management, you have one for regular service provision. The case management authorization should be in the case management account. The regular service authorizations should be in the regular service account, and there shouldn't be any crossover. So I'm not sure, like Laura's saying she got new rates approved by me and the new contract for the new rates. So there's no new contract for rates. You will get an authorization. It's not new rates, it's a tier change. You'll get a new authorization for the new tier. There's another question I need to verify. We are not billing via Thera or the web tool. We are using a billing software. So we are required to have attendance logs, or is our EMR software tracking attendance sufficient? So I don't know about your software. If you're billing Medicaid for a service, you don't have to use the Thera attendance module. If the service is state funded, if DDSN is still paying you for that service, you do have to use the Thera attendance module. If you are billing Medicaid and you're not using Thera or the web tool or whatever, the only point I was really making is, as a provider of service, you have to have verification that the service was provided on the date that you billed the service. So I was just kind of cautioning people with that. Yes, Robin, if they're crossed over, acknowledge, comment it's in the wrong Thera account. The big thing is you got to get that case manager to reissue it to the right account. On only a monthly basis, if we choose DDSN to complete our data entry, will it be completed on a weekly basis or after the first week? So, Allison, it will be completed at least 7 full days after the service delivery, but within 14, right? So there won't be any data entered for a date of service until at least 7 days have passed, because there's an ability for case managers to enter notes for up to 7 days. After that, we will have kind of this 5-day lag where we'll be entering data. So once it's there, you can do whatever you want to with it. You can submit it monthly, you can submit it weekly, you can submit it daily. We don't care, right? What issues will we have with billing when service authorizations overlap? If you've got overlapping authorizations, Christine, let's talk about those offline. We're gonna put something in the system to stop people from doing overlapping auths. We cleaned up a bunch of them. So if there's one out there, it's probably new. And I want to make sure that we get it corrected before 4/1. So you and I can deal with that on the side. For billing, how should units be on an authorization for SLP1 services, monthly, yearly, or weekly? So there's an ability to do it the way that the person needs the service authorized for SLP1. So it may be different depending on who the person is. If you're the provider of service, I suggest that you work with the case manager on how you want, you know, the authorization written. Typically, when you're talking about 15-minute unit services, unless there's some crazy reason not to, the shorter the time span, the easier it is to track. So, Margaret, did you have anything else?
I do not at this time. I just want to thank everybody again for all of your diligence and working collaboratively, and we will continue to do so throughout the transition.
Wonderful. I know everybody's really working hard, so everybody's trying to be available to you guys. If you need us, make sure you reach out if there's something going on that we might be able to help you with. All right, with that, I'm going to move on to the next item on the agenda. Somehow or another, people put my name against a lot of these agenda items. I'm not sure how that happened. But the next item on the agenda is an update related to electronic visit verification, or EVV. The EVV go live date has been postponed at this time. It was initially going to be mid-May, and that date is going to be delayed. After doing some testing and out of an abundance of caution, the decision was made to kind of delay the implementation of EVV. For those of you who provide the EVV specified services, which primarily is going to be companion, respite, and attendant care within the DDSN system, you will need to continue to bill those services using the web tool until we get to EVV implementation. And like I told somebody yesterday, it was the right call, right? I know everybody's ready to get to EVV, as are we, but I think that the decision to delay it a bit is going to be helpful in the long run. It was just something that kind of needed to be done to make sure that things work the way that we need it to. There are a lot of communications that are going out related to EVV, some question and answer sessions and that kind of thing. Just be alert on that, particularly, again, if you are a provider who does respite from your agency or adult companion or attendant care. I think there might be one person that's doing attendant care. So you want to make sure that you're up on the information that's going out around EVV, but we do have a little bit of delay in the implementation. Any questions about EVV? Is there guidance somewhere for EVV on the case manager role versus the service provider's role? Who does this kind of thing? So there is some guidance related to the case manager's ability to run reports and look at things in the EVV world. I want to make sure that providers understand clearly that as we move into this new world, I want to remind you that we're in the process of transitioning to conflict-free case management. So anybody that you provide case management for, if you want to do a service like respite or adult companion, they have to be transitioned to a new case management provider before you can do that, right? Because if you're the provider of respite or companion, then if you're also the case management provider, that's going to be a conflict, just like residential is a conflict, just like day is a conflict. So I just want to, I just want to caution you with that. Jennifer, there's not been a new rollout date established at this point. It's just in delay mode. We will let you know when the new time frame is out. What will the phone number be for the EVV? Will we receive that info soon? So it's not really a phone number. It's an app and a landline and geolocation. You should have already received some communication about it. There is a robust amount of information about the EVV rollout on the DDSN website and on the DHHS website. If you want to touch base with me after the meeting, I can make sure that you have links to that. Other questions about EVV? All right, next item on the agenda, Nci Survey. So whenever in January, a memo went out from DDSN about paying providers to complete the NCI surveys as part of that National Core Indicators project. Everybody should have received that. We started rolling out samples to providers as Alliant reviews were going on. And initially, I think providers misunderstood and thought that they could decide that they wanted to opt out of the NCI surveys. And so I just want to make sure that I'm clear that that's not an optional thing. So it's part of our administrative contract with HHS. It's part of the administration of the waiver. We're paying you to do it. It's expected that providers participate in the NCI. It's really, you guys are doing the pre-surveys, right? So you're filling out these pre-surveys, and then the Alliant folks are doing the full surveys. We've also had some issues where case management providers are getting an NCI survey and thinking, oh, Janet gets residential services over here, so I'm just going to give her residential service provider the NCI survey. That's not really the way it works either. So these samples are based on the person being reviewed. If for some reason you still have conflict in your agency with case management and residential, if the case manager gets the survey and the person gets residential from your same agency, it's fine to have the residential provider complete it, but the samples are agency specific. So we want to make sure that whatever agency got the sample is the person who's actually filling out the pre-survey. Can the family verbally decline doing the survey, or do they have to sign the declination?
They can verbally decline.
Do you hear that? They can verbally decline. If you have enough people decline, we're going to give you replacement people though. So don't think that Jennifer, I know you would never do this, but you know, it's just that thing where if everybody declines, it doesn't mean that you're done. It means that we're going to give you more people.
We have a one-to-one substitution.
Right. Pre-surveys are very lengthy and time consuming. My understanding is the timelines on the request for completion are very short. Why so short of a time? So I think the time frames are twofold. Number one, they're based on the number of surveys you're given, right? So like if provider A gets 2 surveys, we're going to give you a shorter time frame than provider B who got 15. So, you know, that's kind of where we are. If your issue is the turnaround time, talk to us. We will work with you to try to extend the turnaround time. But at the same time, the longer it takes to complete the pre-survey, the shorter amount of time we have to do the actual interview, which is the really lengthy part of the process. Some of us who have had surveys have not yet received anything from Alliant regarding the NCI survey.
That information should be forthcoming. Alliant has the samples, and you know, as their staff are scheduling interviews, they'll be in communication.
No, I think what he's saying is we've been reviewed by Alliant, but didn't get any surveys. Is that what you're saying, Ralph? Yep, that's what he's saying.
Okay. I can follow up.
We'll follow up. We'll make sure you get yours. All right, so the next item on the agenda is the fixed price bid update. I just want to let you guys know that we know that fixed price bid has been delayed. We are currently working through it. We hope to have it to MMO as soon as possible. I don't know what date that will be, but we do have an extension on the old fixed price bid. So at this point, everybody is still qualified and you have your contract in place. The next item on the agenda is leave days. So I just got the leave day report from TheraP this morning in the production account of TheraP. So I ran it, and my intention was to try to get you guys, Sarah was not able to put it in the provider accounts. Only give me one statewide report. So my idea was I'm gonna run it, I'll break it up, I'll send it to you guys, right, so that you'll have it. Whenever I went to work with it, there's a little something messed up with it. So as soon as I get that one little kink worked out, I will send you guys a list of your residential folks and the number of prorated leave days they have from March 1st through the end of the year. Keep in mind that any leave days reported for the month of March are not on that report yet because we have not closed out the month of March. So I just wanted, I know everybody's kind of wanting to know like how many leave days they have and all that kind of stuff. I will do my dead level best to get that to you by the end of the week. Any questions about leave days? All right, that ends my my stint on the agenda.
So good afternoon. I wanted to reach out to everyone to talk a little bit about plans of correction, which may be due for late reporting in the incident management system. We have 25 providers that have received plans of correction notices due to late reporting of initial or final A&E reports and or trends related to incomplete reports that might have been returned multiple times. So we are reaching out to the providers, asking you for a plan of correction. Those plans are due by tomorrow, which is March 31st. The notices were sent out to providers March 3rd. We've received about half of those plans at this point, so this is just a friendly reminder to the rest of the provider agencies to please get those turned in. We want to make sure that you're addressing more than just staff training and the basic expectations, the basic standards. We want to know what you are going to do differently in terms of making sure that staff understand the reporting requirements and you have procedures in place to ensure that that reporting occurs. During last Friday's quality management work group meeting, there were several reference documents that were shared at that time, and the minutes that were sent out later in the day also included copies of those reference documents. If you have any questions, if you need additional copies, or if you want to have a discussion about it, please feel free to reach out to me. You can also reach out using the quality management email address, which is qualitymanagement@vdsn.sc.gov. Thank you.
Okay, I'm Julie Cook, and I wanted to just briefly mention to the provider community that we continue to have a problem with the GERs in Sarah. I ran a report earlier in the week, and in the past 8 months, we have over 10,000 GERs that are in pending status in our system. This is not a new issue. It's been ongoing. It's been addressed numerous times in the quality management work group that we have quarterly. So your QA staff that attend those meetings should be aware. I'm hoping that they're going to give it some attention. But I wanted the opportunity to speak at more of an executive level to ask that you work with your staff to get those GERs reviewed and approved. If you'll remember, in November of 2017, we moved a lot of critical incident reporting issues into the GERs. So therefore, it's important that the GERs are documented, they're reviewed, they're approved, and we make sure that things are being reported properly. If you have issues finding your pending GERs, you can feel free to reach out to me. I'm happy to help any provider that needs that assistance. So thank you.
So we've got some questions about leave days. Leave days will be billed directly to DHHS. If you're billing through TheraP, they'll be automatically billed whenever you identify that someone's on leave. If you're billing in another manner, you will have to bill using the proper procedure code for which you are authorized. And then you will have to add an additional modifier to that procedure code, which is LB, right? So the tracking of leave days, TheraP will tell us how many leave days a person has been prorated to. Then you will, if you bill them through TheraP, you will also on the report every month receive how many have been used and the remainder. If you don't bill through TheraP, it's obviously not going to tell you how many have been used. So it's going to kind of be up to you to bill it correctly. And then HHS and DDSN will be doing some post-payment look at billing for leave days versus amount approved and amount prorated for the year. So Michelle's asking, when you're speaking on leave days, incarceration, is that a leave day or is an absence? So I think it depends, Michelle, on did they get locked up in the county jail for overnight and they're coming right back home, or are they going to jail for a while, in which that's kind of a discharge and then it is an absence. So, but if it's just a situation where somebody got picked up and they're coming home in the morning or something like that, then that would be a leave day. Any other questions? How many days before they need to be discharged? So we're kind of working through some of that in the new residential standards. And we don't really have it completely worked out yet, but here's what you need to, here's the thing to understand. The ability to bill for leave days was updated and allowed by HHS for true leave from the residential facility. So what that means is they're looking at leave as if Tracy went home and she's planning to come back, right? There's never been an intention for leave to be billed as kind of a way to continue to get paid until you find somebody else to go into the bed. So that's why I think, you know, there's not really a number of days, but I would caution everybody in not trying to use leave days to bridge, because that's not the intention of leave days. The intention of leave days is people go home to see their family, people get put in the hospital. I do realize sometimes the hospital turns into maybe they're not coming back. That's probably the biggest thing, but that's it. So, and no, leave days, Laura, cannot be used if somebody discharges before you've filled the slot. You know, it's basically leave, again, is intended to be a planned stay away and you're planning to return. There's not plans for them to go somewhere else. What is 1 to 3 nights in the hospital? It's leave, right? So hospital is leave days.
I'll just do a quick reminder that next week on the 6th, we have the Finance and Audit Subcommittee at 3 p.m. We have Policy Subcommittee on the 12th, also at 3 p.m. And our regular commission meeting on the 21st at 10 a.m. And those are our upcoming events that we just want to make sure everyone has vigilance toward. We know that some of those dates have not been as consistent as usual as we moved finance and policy committees last month.
So Trish is asking, and I think this is for you, what plan of corrections are due March 31st? Are those related to Alliant reviews or something else? I missed part of that.
So the plans of correction that are due on March 31st are specifically for the providers that received a notification on March 3rd that they have a trend of late reporting for abuse, neglect, and exploitation reports, or trends with reports being returned a number of times due to incomplete information. So if you have a plan of correction due, you received a notice on March 3rd, and that notification spelled out for you what your compliance rates were over the past 3 years, or what the trends were regarding the missing information within the reports. If you did not receive a notice, then you have nothing due.
So there's another question about how many days is enough days for leave days. I would just kind of wait until you get the stuff from the standards, but I think at this point, a rule of thumb is, again, only bill leave days when the intention is for the person to return.
Thanks, everyone, for participating in this meeting. We look forward to seeing you next month, if not before, in one of our commission meetings. Have a good day.
Thanks. Bye.